Okay, so I'm going to be presenting on obstetric emergencies today. So the conditions I was going to talk about: preeclampsia and eclampsia, the HELP syndrome, postpartum hemorrhage, amniotic fluid hemorrhage, and just some points about CPR in pregnancy. So just some definitions of what we define preeclampsia and eclampsia as. It's a spectrum of disease with pregnancy-induced hypertension at the lower end. This is hypertension in a pregnant woman who does not already have a central hypertension and without proteinuria. Then preeclampsia is when you also have proteinuria, and eclampsia when there are seizures, and that's in 1% of patients with preeclampsia. Blood pressure varies during pregnancy always. Falls in the first and second trimester to the low point between 22 and 24 weeks, and then rises in the third trimester to pre-pregnancy levels. Falls immediately after delivery, but then rises and peaks on the fourth postnatal day. Preeclampsia rarely occurs before 20 weeks of gestation, but can occur at any point and may continue for up to 48 hours postpartum. It's not a condition that we precisely understand why it occurs, but it seems to be that there's a genetic predisposition, and there's some indications from research that there's a problem with the development of the placenta and reduced placental perfusion, resulting in a need to increase the blood pressure to get the blood across the placenta. So, symptoms that women will present with are headaches, visual disturbance, restlessness, and epigastric pain, nausea and vomiting. They, apart from hypertension and proteinuria, will exhibit fluid retention, hyperreflexia, and if you look behind the eyes, signs of hypertension there. And features associated with preeclampsia can be reduced plasma volume and cerebral edema, raised peripheral vascular resistance, and they can develop hepatic impairment, AKI, and BIC. It can occasionally be managed either in a day centre setting, or it's often managed obviously in an obstetric ward. But severe cases, people whose blood pressure is particularly high, over 170, 110, or where there's significant proteinuria, where they're very symptomatic, got abnormal biochemistry or haematology, and if there's any sign of fetal distress. The only cure is delivery, and so it's always a balance between prolongation of the pregnancy versus the risks to the mother, and so that's always a multidisciplinary decision on when delivery should take place. And you can, with controlled volume expansion, actually reduce the drivers of the systemic hypertension, but you've got to be cautious about, because there's significant proteinuria, you don't want to create fluid in the wrong places. And the drugs to consider on the obstetric ward, they'll be thinking about things like amphetamine and methyl-dopa, and our setting we'll be looking more towards labetalol and hydralazine. And then seizure control is mainly with magnesium therapy, and levels are kept high between 2.5 and 3.75, and that can be used obviously in eclampsia, but also as prophylaxis against seizures if there's a patient with severe preeclampsia. Low doses of benzos can also be used, and there's some references to them. And then the HELP syndrome, which is probably a variant of preeclampsia, occurs in 12% of patients with preeclampsia, but hypertension is not a universal finding. But the main features are a microangiopathic hemolytic anemia with elevated liver enzymes and low platelets. It's most commonly found in multiparous women, and again may present up to 48 hours postpartum, not necessarily during the pregnancy itself. The first findings on the blood will be a rise in the AST, and then the LDH rises after that. On the blood film, obviously, signs of MAHA, schistocytes and polychromasia. The frank anemia is actually uncommon in her syndrome. And treatment is basic resuscitation. The major complication that can occur that is major cause of mortality is hepatic hemorrhage and a ruptured subcapsular hematoma. So an ultrasound liver is always recommended. Magnesium seizure prophylaxis again in this situation because eclampsia can develop. Plasma exchange in severe hemolysis and thrombocytopenia. And platelet transfusions aren't really useful in this setting unless there's active bleeding. Steroids have been used in the past to increase platelet count, but have actually been found not to affect the maternal outcome. There'll be in time to have a look at those. So then the leading cause of maternal death is postpartum hemorrhage, and it's usually due to incomplete uterine contraction after the birth. It may be due to retained products of placenta. It can be primary, which is blood loss of more than 500 ml in 24 hours, within 24 hours delivery, or secondary, which is between 24 hours and 6 weeks after birth. And the treatment is much the same as in any major hemorrhage, resuscitation. And then the specifics, fundal massage and aortic compression, which is the sort of picture that most people are familiar with from medical school. A hand inside and hand on top. And then drugs-wise, oxytocin to stimulate uterine contraction, and prostaglandins as well. You need to make sure that the placenta is intact and deliver the placenta. If not, with cord traction or manually interfere to under regional block. And the B-Lynch suture, which is a suture over the fundus of the uterus to bring it down and compress it, with 2 sutures. And also other manual physical interventions like intrauterine balloons or packing can be considered by the obstetricians, and then in interventional radiology you can consider coil embolization. Previously people used to ligate the iliac artery, but then that's not been found to be benefit. Ultimately, again, hysterectomy is sometimes necessary, but obviously something you want to avoid. Amniotic fluid embolus, another thing specific in pregnancy, is very rare, 1 in 10,000 pregnancies, but has a very high mortality. 80% of women die at 30 minutes. And it can occur any time in pregnancy, but most commonly during labour, 70% of cases during labour. Symptoms: rapid onset, chills, sweating, shivering, anxiety and coughing. It's sudden onset, breathlessness, cyanosis and low blood pressure. Seizures also occur in this condition. And the management is supportive. There's no specific management for amniotic fluid embolus. It's aggressive fluid resuscitation, inotropic support on ICU environments. There's people don't exactly know how this occurs or what the pathophysiology is. There's some thinking that it might be some kind of anaphylactic-like reaction to fetal products. And so adrenaline has been used in some cases, and there are case reports coming out about use of ECMO. And then I thought I'd just finally cover some specific points about CPR in pregnancy. The common causes to think about are inherent cardiac disease, PE. This is Psychiatric disorders is something that comes from the Resource Council UK's guidelines to think about. I don't know exactly what I meant by that. I'm presuming it's I think they mean overdoses and self-harm. Obviously, the hypertensive disorders that we've just discussed, sepsis, hemorrhage, amniotic fluid embolism, and early on ectopic pregnancy, and then the things that you have to think about in any woman of childbearing age, whether they're pregnant or not: anaphylaxis, drug overdose, and trauma. So after 20 weeks, you're familiar with doing CPR in the left lateral position to reduce compression on IVC. Before 20 weeks, it's not been shown to be necessary, and there's no sort of specific guidance on how many degrees you have to turn the lady to the left. It can be easier in settings like theatre where you can tilt the table, but it's just give it a go, I think, is the guideline. They also recommend securing IV access above the level of the diaphragm because of the pressure on the IVC inferiorly, and involving a multidisciplinary team early to consider emergency cesarean. They also recommend, and this is again the Resource Council UK's guideline, to intubate early due to the increased risk of aspiration during pregnancy. And some additional reversible causes to your usual 4H's and 4T's. Well, not all additional, but to think about specifically in pregnancy is hemorrhage. Drugs, you can think about magnesium overdose if you're treating for eclampsia, and give calcium for that. Cardiovascular disease, MI can present atypically in pregnancy with epigastric pain and vomiting. And also you need to think about things like peripartum cardiomyopathy, which is specific to pregnancy, and those considerations.